We are very excited to welcome today's speaker, Dr. Crystal Schiller, an associate professor in the Department of Psychiatry at the University of North Carolina. Dr. Schiller's research focuses on the impact of ovarian hormones on behavior and brain function in women. And her previous work demonstrated that estrogen and progesterone play a role in bulimia nervosa, smoking behavior, and postpartum depression. She is currently using functional MRI to examine how estrogen and progesterone provoke changes in neural circuits responsible for depression. This research may improve our understanding how hormonal changes during pregnancy and postpartum period trigger the onset of major depression in some but not all women. She also hopes that by contributing to our knowledge of biological basis of postpartum depression, this work may also serve to reduce the stigma and self-blame associated with mental illness in women. And Dr. Schiller, we are thrilled to have you with us today, and the floor is yours. I will stop sharing my screen.
All right. Well, thank you so much for having me. I was saying when I joined the call that my there's a little bit of construction going on outside my house today, and so that's why I'm wearing these giant earphones to try and block out the sound. And so hopefully that won't interfere with our call at all today. But thank you all so much for being here and for inviting me. I was really honored to get this invitation, and I'm excited to share the research that we're doing at UNC Chapel Hill. All right, and I'm happy to answer questions as we go along. So if you have questions, please feel free to put them in the chat or I think, with this amount of people, we can probably unmute ourselves and ask questions as well. So I welcome discussion along the way. All right, so today I'll be talking about our work on the impact of ovarian steroids on brain function and mood across the reproductive lifespan. All right. So first I want to start by acknowledging my fantastic collaborators, the UNC Center for Women's Mood Disorders, the community advisors, of course, the research participants who participate in our studies, of which there have been many, and you'll see it's a Herculean effort to get through the studies that we do. So always want to express gratitude for the people who participate in our work. I have a good team of postdoctoral fellows, graduate students, and project coordinators, many of whom you can see pictured here. I also want to acknowledge the funders who support our work, the NIH, PCORI, and the Foundation of Hope, which is a local foundation in North Carolina that raises money for mental health research. And I've been fortunate to have a strong relationship with them over the last many years. So thank you. There we go. All right, I'm going to rearrange everything on my slide so I can, or on Zoom so I can see the slide. All right, so as you all probably know, despite decades of research, depression rates are increasing and differentially impacting women. And when I say women, I'm including both gender and sex here because they are intertwined in these statistics on this slide. So depression is now affecting 57% of adolescent girls and 24% of women. So the rates are quite high. 30% of adolescent girls now report seriously considering suicide. And depression is still twice as likely in girls and women than boys and men. And the period of increased risk for depression begins at puberty and persists through menopause. And so that's, I think, nicely depicted in this graph on this slide, although this graph is getting a little old now. It was published in 2003, so more than 20 years ago. But you can see really nicely here the separation between females and males as they reach puberty in terms of risk for depression, and then it persists through menopause. And so this is actually what got me interested in studying this topic. So why is it that biological females are actually at increased risk of depression? And I started to wonder about ovarian steroid hormones. This graph maps on remarkably well to the percent change in estrogen over the course of the reproductive lifespan. And so you can see estrogen is increasing here in adolescence, remains elevated again, increases and becomes highly variable in the perimenopause, and then declines precipitously in the menopause. And so it's, an interesting coincidence, right? That the rates of depression really map on to this change in estrogen. All right, so I set out to pursue this and really understand how reproductive steroids modulate the brain. And what's become very clear is that these steroids, in particular ovarian steroids, modulate the motivational systems that are essential for our survival. They modulate eating behaviors, reproductive behaviors, and maternal behaviors. And in many ways, the role of ovarian steroids on the brain are highly adaptive. And so I was very interested in figuring out how this goes wrong and how that creates risk for depression in females. So I began studying reproductive related mood disorders, and today I'm going to focus on our work in postpartum depression, as well as our more recent work in perimenopausal depression. We've done some work with neurosteroids in premenstrual dysphoric disorder, and I'm leaving that to the side today. All right, so let's start with perinatal depression. And these figures were made by AI, which has kind of been an interesting experience in seeing how AI can help us in generating more interesting visuals for talks. So first, I want to zoom out and talk about the risk factors or things that we know contribute to perinatal depression, because while I study hormones and biology, obviously the risk factors and contributors to perinatal depression are broader than that. And so I kind of approach it from a biopsychosocial model and think about it in these different categories of risk, but obviously they're all sort of intertwined. Um, Things that contribute to perinatal depression that are very clear is personal history of major depressive disorder or perinatal depression, anxiety during pregnancy. There's some personality factors like neuroticism or low positive affectivity, and fragmented sleep obviously contributes to depression. In the social realm, poor social support, relationship dissatisfaction, being younger, being single, having a trauma history contribute to perinatal depression. And then in biological factors, we have thyroid dysfunction, immune dysregulation, stress reactivity, a genetic predisposition. And some of this work has been done by my colleagues here at UNC, as well as family history. And these things combine in the perinatal period in a special way because of the reproductive trigger that women experience during pregnancy and childbirth, this tremendous hormonal shift that I'll show you in a second that contributes to perinatal depression. All right, so the this creates some challenges in studying the biological causes of perinatal depression, because we know that psychosocial factors play a big role, and as a result, there's a lot of diagnostic heterogeneity. There are a lot of different ways to get a depression diagnosis, and so two patients with the perinatal depression diagnosis may have very different onset timings and different sets of symptoms. They also experience a lot of biological shifts during this period because we know that estrogen and progesterone regulate basically all of our biological systems. And as I mentioned, hormones are changing and highly variable during pregnancy and the early postpartum period. All right, so what we know is that circulating hormone levels change dramatically during and after pregnancy. And so I've been focused on this purple line here, estradiol, and the blue line, progesterone. But you can see shifts in a lot of other hormones as well. And so I'll talk about how we focused specifically on estradiol and progesterone. All right, so in our work, we use experimental models to try and understand how hormones are regulating the brain and mood in women. And our participants in this first study were 30 euthymic non-pregnant women. 15 had a history of postpartum depression, and 15 had no history of postpartum depression, despite having given birth before. All of the women in these experimental studies are not pregnant at the time of enrollment. They go through a period of screening. They do a structured clinical interview to determine their mental health history, and we do really deep phenotyping of these individuals. They also get OBGYN visit and pelvic exam to ensure that they are medically healthy to participate in this study. Then we time the first imaging session to their menstrual cycle. So in the early to mid follicular phase, their hormone levels are pretty low and relatively stable for the menstrual cycle. They do this first imaging session and they get their first injection of a drug called Lupron or lupulide acetate, which stops ovarian production of estradiol and progesterone. So it creates this sort of stable hypogonadal state so that we can tightly control how much estradiol and progesterone is in their body at any one time. And the point of this is to mimic the hormone profile of pregnancy and the postpartum. This protocol replicates a study that Peter Schmidt and David Rubino did at the NIH in the year 2000. So anyway, we give them Lupron. It's an IM injection. They get 4 of them. Like I said, this creates hypogonadism. In the first phase here, they get placebo, and participants are unaware of what they're taking. So they know that they'll get estradiol and progesterone at some point, but the purpose of giving them placebo is so that we can blind them to when they switch on and off of estradiol and progesterone so that their expectations about how hormones impact their mood don't influence their mood ratings in the study. So then we bring them up to a pretty good dose of estradiol and progesterone. They get hormones for 8 weeks in this protocol, and then we switch them back to placebo to cause an abrupt drop in hormones similar to what we see during childbirth. So this period when they're getting hormones is called add back, and then when they go through withdrawal, that's when their hormone levels are dropping. Midway through the withdrawal phase is when we did the second imaging session because we expected their mood symptoms to be highest here during withdrawal. All right, so what we see is that those with a history of postpartum depression showed increased anhedonia during add back and withdrawal. And you can see that the peak was here in late add back. It was very interesting to us that they started, their symptoms were differentiating from those without a history of postpartum depression in early add back because we expected that it would really be withdrawal. So for the brain imaging part, we wanted to identify those who were most sensitive to changes in hormones because we were interested in this hormone sensitive phenotype of postpartum depression. So again, not including everyone who's had a history of postpartum depression because not all of them are probably sensitive to changes in hormones. And that's just what we found here. So when we we defined hormone sensitivity as a 30% increase in mood symptoms during reproductive hormone change, as defined by the Inventory of Depression and Anxiety Symptoms. And we found that among those with a history of perinatal depression or postpartum depression, um, 11 of the 15 met this criterion for hormone sensitivity. And actually, one of the 15 controls did as well. And when I was doing the interview at the end of the study, which I did with every participant, I asked her, why do you think you were sensitive to changes in hormones in this study? And she said, well, I was in this study because my mom had postpartum depression, my sisters had postpartum depression, and I really wanted to contribute to science on this area. And I thought, oh gosh, this was a terrible control. Um, so even though she didn't have a personal history of postpartum depression, it ran in her family. And now we use that as a criterion for excluding controls, but we didn't at the time. So her data are excluded from the hormone sensitivity group when I show you the imaging results. But it was interesting. So the people who were hormone sensitive, who had a history of perinatal depression, were really distinguished from the people who were not hormone sensitive, even though both. So this is representative data from two participants in this top panel. It was a person with a history of perinatal depression who had met our criterion for hormone sensitivity, and this was the typical pattern. So there's increased symptoms during add back and withdrawal, and then it returns to baseline by follow-up once they're off all of their medications. And then the opposite trend for well-being. So reduced well-being during add back, and things kind of improving after that. Our This person also had a history of perinatal depression, and I hope that this will convince you that there is really a phenotype of hormone sensitive perinatal depression where you can see there's just no change. And this is what a lot of our controls look like. They felt totally fine despite the fact they were going through these wild hormone fluctuations. So in our imaging protocol, we use the monetary incentive delay task so that we can probe this neural reward system, and that is replete with estradiol and progesterone receptors. And in this task, it's great because we have the ability to look at brain function during the anticipation of rewards. So these cues, participants learn that they indicate that they stand to win money and then how much money they stand to win. And it distinguishes this reward anticipation from reward outcome. So what happens? Did they get the money or not? All right. So our participants showed decreased activation of key regions of this reward system during hormone withdrawal. So this shows activation of the putamen, which was reduced actually regardless of whether women were hormone sensitive or not. We were hoping this task would distinguish people who are hormone sensitive from those who are not, but instead what we found is that everyone showed decreased activation during reward anticipation in the putamen. And this is normally what you see in people who are depressed. Um, our participants also showed decreased activation of the left postcentral or supramarginal gyrus. This wasn't part of our hypotheses. And in this area, lower activation was associated with increased irritability. It was not associated with anhedonia, which was interesting. And so we got really interested in this irritability finding. And this shows a reanalysis of the data. And you can see different symptoms emerging over time and kind of how they stay elevated or not during this phase of hormone add back. So this is early add back when we're just titrating up the dose. This is the full dose of estradiol and progesterone. And it's interesting what happens with irritability. Almost immediately when we started hormone add back, there were several participants who became very irritable and were calling my office saying, like, I don't know if I can do this study. I feel very irritable. I'm yelling at my partner and my kids, and I just don't feel like doing anything. I'm just trying to avoid them so I don't cause problems in my relationships. And so for some of them, we actually truncated the protocol, and because, they had such an extreme reaction to it. And then, for others who were able to tolerate it, they showed that irritability was the symptom with the highest peak and the longest persistence in this study. You can see this is the daily rating of severity of problems by Endicott et al. So we had daily ratings of people during this time. You can see anhedonia, where is it? Less interest, this pink one. It's still peaking during add back, but then, and it stays somewhat elevated, but it's just not as robust as that irritability finding. So results of this study suggested to us that normative changes in ovarian hormones may suppress areas of the brain that are responsive to reward in those who are hormone sensitive, but really in all of our participants. I think this carries important implications for attachment and maternal behavior, which have been shown to be impaired in those with perinatal depression. And this, is something that many of our participants deal with. So, knowing how hormones regulate the reward system is important, and it helps us explain what's happening to patients in our clinics. So I was interested in this irritability finding. So we basically replicated that same study design, and here we're trying to go after irritability. We have a even smaller sample size in this study. These were funded by NIH R21s. So for those of you familiar with that mechanism, it is great because they reward high-risk studies like this, but the budget is fairly limited and Lupron is extraordinarily expensive. And this study also happened during the COVID-19 pandemic. So I will describe how that impacts results here in a second. But it definitely impacted our sample size. The other thing we did here is we shortened the period of add back to just 2 weeks, since we were able to distinguish groups so quickly. To reduce participant burden, really truncated the period of add back here. And then we timed the imaging to occur during add back instead of during withdrawal, since we saw peak symptoms of both anhedonia and irritability during that add back phase. So quickly, this is what we found during add back. Are those with a history of postpartum depression, again, showed significantly reduced well-being compared with those without a history of postpartum depression. But then they improved a bit during withdrawal, such that they weren't statistically significantly different from those without a history of postpartum depression. Um, and in dysphoria, it's just, the opposite. The group with a history of postpartum depression showed increased dysphoria during hormone add back, and then it reduced a little bit during withdrawal. People are often surprised when I present these kinds of results, that actually our participants who are hormone sensitive do worse during add back than withdrawal. And I think a few different things are going on. It's a little tricky to tell in our study design, because we've administered estradiol and progesterone together to mimic what happens during pregnancy and the postpartum period. And in future research, we need to administer estradiol and progesterone separately so we can determine which of these hormones is driving our results. But I do know that there's a lot of individual differences in response to hormones. So some people are more sensitive to estradiol, others seem to be more sensitive to progesterone. some are sensitive to increases, others are more sensitive to decreases. And so that's the kind of thing that we need larger studies to investigate in the future. All right. In this study, because we were interested in irritability, we used an affective Posner task to provoke frustration during fMRI. And I won't go into the details of that, but I will say that our participants did find the task frustrating. Here we did distinguish between groups. So those who were hormone sensitive, using that same definition as in study 1, showed increased activation of the right putamen and left caudate during hormone add back relative to baseline and relative to those who were not hormone sensitive. And so this is exactly what we expected to see during frustration. All right, and now these slides are a little complicated. They haven't been published yet. We're still working on the best way to visualize these data. But what I can tell you is that those with increased left caudate activation from baseline to follow-up are depicted by this blue line here. So they're one standard deviation above the mean. They experienced increased irritability during add back and then decreased irritability during withdrawal. So essentially what I'm telling you here is that our brain findings correspond to changes in mood and in this case, irritability specifically. And then same thing with the putamen and well-being. So this well-being scale we have thought of as sort of being our measure of anhedonia if you were to reverse it. So it's no surprise then that the right putamen, and here's our at baseline. So right putamen activation at baseline, those with higher activation experience reduced well-being during add back or more anhedonia. And then same for change over time, those with increased right putamen between baseline and follow-up experience reductions in well-being during add back. All right, so what this tells us is the left caudate activation may play an important role in hormone-related irritability, and the right putamen activation may play a role in hormone-related anhedonia. It's interesting to me that the putamen was implicated in both study 1 and study 2. I mean, like I said, we were trying to probe the reward system in these studies, so maybe it's not so surprising that we found some results, but it's interesting that the putamen keeps popping out, and it suggests that it may be playing a role in both sensitivity to hormones and perinatal anhedonia. These were both pretty small studies, so we do need larger studies to determine the independent effects, as I mentioned, of estradiol and progesterone, and to determine, which phenotypes may be more or less sensitive to GABAergic neurosteroids like zuranolone and some other drugs that are in development now. So I also just want to quickly point out that we have a large clinical program at UNC. We have a number of psychiatrists, psychologists, and social workers providing inpatient and outpatient treatment. We have an outpatient zuranolone program treating postpartum depression. We have a psychotherapy program, including full model DBT and trauma therapies, and we are conducting many clinical trials. We have historically done trials on zuranolone and brexanolone. Just wrapped up another brexanolone trial. We have a psilocybin trial in progress. We wrapped up a large behavioral activation trial showing that behavioral activation rapidly reduces depression and suicidality in perinatal women, and that nurses and doulas are just as effective as psychologists and psychiatrists at providing behavioral activation, and that telehealth worked just as well as seeing someone face to face. And we have some studies now funded by the Foundation of Hope looking at CBT for acute perinatal suicidality as well. We have a number of tools for clinicians available, and I can make my slides available. The manual for that behavioral activation clinical trial, as well as the patient-facing workbook, is available for free on the summittrial.com. And then we have a book on our approach to treating perinatal depression that's available as well. All right, so now I'm going to switch gears and talk about menopause. So, many women experience emotional changes during the transition to menopause. Depression is 14 times more common in the transition to menopause. Actually, 50% of women experience clinically significant depression symptoms. I think that surprises a lot of people. And 10% of perimenopausal women receive a diagnosis of depression. Those with a history of depression are at highest risk, probably unsurprisingly to you. Okay, so this study suggested that it was this stage of the menopause transition, straw stage -1, that you see the increased incidence of depression. This is true in women with and without hot flashes. It was, for a long time, it was thought that depression during menopause was caused by the distress and functional impairment associated with hot flashes. And now we know that it's independent of that. This straw stage -1 also corresponds to the period of time when estradiol levels drop. So during stage -2, this is the early perimenopause, levels are highly variable. They're still somewhat variable in this late perimenopause stage, but the on average levels are lower, and this is when depression levels are highest. And Peter Schmidt's work has shown that estradiol treatment reverses depression in this late perimenopause. So you can see depression symptoms dropped in this estradiol treatment group. And this was after just 3 weeks of estradiol treatment. Okay, so I mentioned variability. This is a paper from our group showing high levels of variability, and these are urine metabolites of estrogen, progesterone, and follicle stimulating hormone. You can see, day to day, week to week, these levels are changing very dramatically. And then, interestingly, so this person is clearly perimenopausal. They don't have the sort of predictable pattern of estrogen and progesterone that you would see over the course of the menstrual cycle. And this is the reason that we don't use hormone testing to diagnose transition to menopause, because one day they may look, you know, perimenopausal, and the next they would look like, they were pregnant or something. So it's single hormone tests are relatively useless during this time. And I try to reiterate that when I give talks, because there are many people out there trying to sell hormone tests to women, and it's a unfortunate waste of money in most cases. All right, so here we try to replicate Peter Schmidt's study showing that we could produce antidepressant effects with estradiol after just 3 weeks. And we did brain imaging at the beginning and at the end. And then we added progesterone in this final week to stimulate a menstrual period. We included women with current major depressive disorder, as well as healthy controls in this trial. All right, I kind of already went over that piece. Interesting. What we found is really symptoms were elevated across the board. So they met criteria for depression, but they also were reporting a lot of irritability, which, as you know, is not a criterion for major depressive disorder in adults. They're reporting a lot of insomnia, but also things that we didn't really expect: social anxiety, panic, trauma symptoms, somatic symptoms, obviously vasomotor symptoms. But the vasomotor symptoms were higher in those with depression in this study. And the interesting thing to me was that even though these people didn't meet criteria for any of these other diagnoses, they just were depressed. The estradiol reduced symptoms really across the board. It wasn't just dysphoria and anhedonia like we would have expected. And so you can see just over the 3 weeks of treatment, our depressed group in blue shows reductions in symptoms. They don't actually see the biggest reduction in anhedonia, although it was statistically significant. They see bigger reductions in dysphoria and irritability. And I'm not going to show you graphs for every symptom, but they all essentially look like this. And the interesting thing was that so we looked at estradiol levels during treatment, and those who had the highest level of week to week variability during treatment actually showed the most severe symptoms. So when estradiol was effective at reducing variability, either because it raised their levels up enough or because it reduced the noise, that those participants did better on estradiol. Here we use the monetary incentive delay task again. And again, across both groups, we found that estrogen reduced activity in several brain regions. But here it actually corrected cortical hyperreactivity to reward anticipation in those with depression compared with controls. So this was a cluster spanning the right inferior, middle, and precentral gyri, and you can see that those with MDD that had onset during the menopause transition, when we gave them estradiol, the activation in this region was reduced, whereas in our controls, this was not a statistically significant difference. It stayed the same. All right. So we also had a resting state scan, and what we found there was that estradiol reduced resting state connectivity between the ventromedial prefrontal cortex and amygdala. And this was associated with the change in depression and in anhedonia in our participants. We also looked at structural changes. So just 3 weeks of estradiol increased hippocampal volumes, and there was a group by time interaction. It increased hippocampal brain volume in the controls, but not the MDD group. So we replicated this with a different estrogen drug called Duovy. It's a drug that's made by Pfizer, which is a tissue selective estrogen complex. So it combines conjugated estrogens with another drug called basidoxifene, which is a selective estrogen receptor modulator. The basidoxifene blocks estrogen receptors in the uterine and breast tissue. So women can take estrogen without progesterone when they take Duovy. Because we had seen such significant results after just 3 weeks with transdermal estradiol, we replicated that same timeline here with DuoV. It was a very small study, just 10 women, but you can see our preliminary results showing a rapid reduction in symptoms really across the board. And the dotted line here shows the clinical cutoff for each of these scales. So women were below the clinical cutoff after just 3 weeks. All right. So from this, we can see that estradiol regulates mood and brain function during perimenopause. Our data provide evidence that estrogen or estradiol regulates depressive symptoms, including anhedonia, dysphoria, and irritability. And the reduction in cortical hyperreactivity to rewards may partly be responsible for these effects. And our long-term goal here is to improve our ability to identify those at risk for hormone-triggered mood dysregulation to prevent illness expression in the first place. So identifying who may be most at risk so that we could treat women earlier and educate them earlier about the risks of menopause and mood dysregulation. We are continuing this work now with an RL1 to use simultaneous PET MR to not only look at brain activation, but also dopamine receptors in women. Right. We also have a public-facing menopause seminar series that has been supported by UNC, and all of our webinars are archived on our website, and we really try to approach menopause from lots of different angles and bring in experts to talk to the public about different topics. So our last one was about sexual health. We've also talked about how to tell fact from fiction and sort through all the misinformation out there. We've talked about hormone replacement therapy, of course, and cognitive function during the menopause transition. I feel really lucky to get to work with so many great scientists and physicians on this series. We also have a midlife women's mood disorder clinic at UNC, and there we do specialized consultations and make recommendations for managing hormones and mood. And then we do short-term behavioral interventions like CBTI and behavioral activation. All right, so in sum, our key takeaways today are that there's a type of ovarian steroid fluctuations influence mood, reward processing, and brain function in women. That reward and emotion processing systems are implicated in sensitivity to ovarian steroids. Although I will say the source of this susceptibility remains unknown. When Peter comes to talk to you, he'll talk about his work at the cellular level, and we've been collaborating on that to try and understand how gene expression may help explain some of this. And we think that maybe targeting specific brain regions in the reward system, like the caudate and putamen, may help improve treatment outcomes. And across our studies, I think that the common thread is that hormone destabilization provokes symptoms in a subset of sensitive women, and then hormone stabilization seems to reduce these symptoms. All right, so our goals on my team are to expand studies linking ovarian steroids to neural and behavioral changes using multimodal brain imaging and deep phenotyping. We're really interested in integrating AI tools to model hormone, brain, mood interactions and predict treatment response. We are excited to collaborate on translational studies to test interventions in diverse perinatal and midlife populations. And ultimately, our goal is to develop personalized medicine strategies for hormone-triggered mood disorders. So if any of this interests you, please feel free to get in touch. My email address is there, and you can find me on LinkedIn. And then we also have a lot of training programs. So if you're looking for training in any of these areas, we have a T32 postdoctoral fellowship in reproductive mood disorders. We have a psychiatry fellowship. We have internship tracks for clinical psychologists focused on this work. We have a psychiatry residency program, and then we have undergraduate research programs as well. So thank you.
Wonderful talk. Thanks so much. I think we can start for a Q&A session. I will start by asking about your perimenopause and depression study. It was a very important study, and I'm uh, I'm interested in like how we can use different kind of treatments. And previous studies have shown that if we use estradiol and progesterone together, it might be more beneficial for cognitive impairment and Alzheimer's disease during the perimenopause. I was just wondering, like, why you specifically focus on estradiol, because you wanted to like investigate only the estradiol effect, or are you planning to also try estradiol plus progesterone? And
Yeah.
related to this, I also wanted to ask if you control other features like menopause, perimenopause age, or number of kids, this kind of, or prior depression when you were comparing the impact of estradiol on depression.
Yeah, great questions. So when we control for age and vasomotor symptoms, our results hold. We have not controlled for number of children or things like that. These are that first study that I showed you was my K23. So again, it's a small-ish sample size, and with our R01, we'll be able to control for more variables. With regard to the question about progesterone, it's interesting. So, in women with mood disorders, um, progesterone either has sort of a neutral effect or a negative effect on mood. So, for some women, progesterone actually increases irritability, and our participants show increased mood symptoms when we add back the progesterone in that final week. Not all of them, but some of them. So that's why we have not really gone after progesterone as a treatment. And many of our patients in our clinic do best on Duovy compared with transdermal estradiol plus progesterone, probably for the same reason. So anyway, that's something that I'm interested in looking at whether there are different phenotypes that may be more responsive to estradiol or progesterone, but that's in its infancy right now. We haven't done much with it yet.
I'll chime in. Crystal, that was fantastic. And I'm just blown away at what you guys have built. You have such a long history at UNC of being real leaders in this space of reproductive psychiatry, and all of your training programs, all of your seminar series, in addition to your, kind of translational and clinical work is really just extraordinary. So for the trainees in the audience, rush to UNC. You would be so lucky to be in their orbit to learn from the best. I have one sort of specific question that I think maybe your R01 is going to get at better, but you had this really kind of beautiful approach of thinking about the biopsychosocial model. And I would love, like, as your sample starts to expand, for you to I want to know how sort of the endocrine manipulation interacts with everything else happening at home, life stressors or whatever, because you can imagine some of those symptoms could be exacerbated or even buffered, the sort of resilience effect based on all of these other bits of the biopsychosocial model. So I don't know if you have started to probe that yet, or you're waiting for the bigger sample, but.
Yeah, we're starting to look at that a little bit in our R01. We actually wrote a SCORE grant to do just that. Emily, it
Oh,
did not get
cool.
funded, unfortunately,
Okay.
but
I was
so
not the reviewer.
yeah, no. We broke it up into individual R01s, which just went in last week. So Yes, the plan is to begin to look at sort of the independent and synergistic effects of estradiol, progesterone, and stress, um, really across the reproductive lifespan. So we submitted one to do this in puberty and another to do it in menopause. And yes, I think that is the next frontier.
That's awesome. That's really cool. Well, I can't wait. Fingers crossed. And maybe we'll jump over to the Q&A. It looks like Magdalena Martinez Garcia has a question. She says, "Hi, such a great talk. Congratulations on this hard work. Such unique experiments to explore hormonal sensitive perinatal depression. I was wondering, was it difficult to recruit these participants? Were they motivated to participate? What were their incentives? Again, congratulations on your work."
Yeah, thanks so much. Yes, we have a wonderful group of people who selflessly participate in our research because they want to give back and want to find the answers so that other women don't have to experience these same symptoms during pregnancy and menopause. In the Lupron studies, we pay people pretty well. They get around $1,500 for participating in these studies. And so, you know, we try not to make it a coercive amount of money. It's still a lot of work. They're doing stuff for us, as I mentioned, every single day during those very long studies. But yeah, that's why people participate, mainly because they want to contribute to science and prevention. Um, and it was hard, it is hard to recruit people because we have such stringent inclusion exclusion criteria for these studies. So, you know, people with a personal history of, you know, heart attack or blood clotting or family history of breast cancer, like all these things rule people out. And so they can't be on any medications, no hormonal contraceptives. So it's like impossible to find people to participate in these studies, not because they don't want to, but because there's such strict inclusion exclusion criteria. Um, all right. Can you share advice or ideas on building infrastructure in clinical settings to improve women's mental health? Yeah, I mean, I'm very lucky that I'm at UNC Chapel Hill. David Rubino started the Center for Women's Mood Disorders um, uh, many years ago now, and then Samantha Meltzer Brody stepped in as director and continued to build this infrastructure. I became the director just last month when Samantha became executive dean of the School of Medicine at UNC. So I have inherited this fantastic infrastructure. But I think one thing that we do well is we recruit clinician scientists to do this work. So all of us, despite having grants, and teaching, we also all still see patients. And I think that kind of synergy is really important to hear directly from people and see directly what people are struggling with, because that guides our clinical questions and the research that we do. And we meet together. Not every clinician is the researcher, not every researcher is a clinician, of course, but we work closely together to recruit research participants, to guide our thinking about clinical interventions. And so it's very synergistic. We have had to be really creative about how to build that collaborative kind of environment in this new virtual world. Um, so we have, um, you know, happy hours and those kinds of things, but we also have Zoom meetings and time to discuss, you know, complicated clinical cases where our clinicians discuss complicated clinical cases with researchers, and researchers discuss their ideas with our clinicians. And as I mentioned, we're more and more engaging patient stakeholders as well to guide this process. What are they? were the ages of the participants relevant for the perinatal and perimenopausal groups? As I mentioned, we do control for age in our models, and so the results I showed were not dependent on age, but it's a great question because people can become pregnant and also go through menopause at a wide age range. So it's important to consider how reproductive aging and biological aging are related. And I think with larger studies, we'll be able to hopefully tease some of that out more. Lisa Mosconi's group has done a fantastic job of looking at reproductive aging independent of biological aging, and she has some really interesting effects.
Fantastic. Well, we are right on time, hitting up against the hour. So another round of applause and thank you, Dr. Schiller, for joining us. Really phenomenal work. Everybody on the call, I would say tell your friends. You can find Dr. Schiller's talk on our YouTube channel probably by the end of today. It'll be up there for all to see and share. And we'll see you back here again next week. And Crystal, I hope to see you maybe at ACMP or around.
Yeah. Thank you so much. I appreciate it.
Thank
Take
you.
care.
It was wonderful. Bye.
Bye-bye.